So we're going to go to another pretty routine case. It's a 35-year-old male with severe chronic rhinosinusitis. I think maybe one or two of you have seen this case presentation before. What's interesting is that this consultation took me to the Woodland Park Zoo, and I got a call from one of my colleagues, Al Halal, who many of you know is a laryngologist. And he's been donating his time to our local zoo for decades. About every 5 or 10 years, they call him with a really cool consult. He's seen a Simang monkey with vocal cord paralysis. He looked in a lion's ear. And we grew up at University of Washington in his exam rooms. He has pictures of him and these animals, and we're like, that is so cool. So anyway, he called and he says, hey, we got to take a field trip. So this is the patient. He's a 430-pound Western silverback gorilla named Vip. Vip stands for very important primate. And he's the alpha male at the Woodland Park Zoo. He's the only reproducing male gorilla at the zoo. He has produced 8 females, 6 of them alive, no males yet. And this is him about 4 months before I met him, and he's a pretty ornery guy, as you can tell. You get a close-up view, and you see the snot coming out of his left nostril, and some tearing, some epiphora there on the left side of his cheek, and he was pretty sick. So they called us, and that's myself and Dr. Halal, and this is the area behind the scenes at the zoo. And you walk up and they give you this kind of disclaimer sign here. They tell you got to speak in a quiet voice, don't make eye contact. We're sitting on these tiny little stools right next to Vip the gorilla. So it was kind of intense, and I was freaking out before I even got there, and now I was really nervous. But when you look close, this is a close-up I took with my phone, you can see now the drainage is coming out of both nostrils, right in that center box between the cage. And to the vet's credit, so the vets at the zoo, they were fantastic. I think they take care of, talking about collected culture, so they cultured this snot, granted not endoscopic, just swabs up the nose. I wouldn't volunteer to do that in an awake gorilla, but they did. And first time it grew up Bacteroides moraxella, they treated him with culture-directed antibiotic therapy. A month later, still going. They cultured it again. Enterobacter, they gave him Bactrim, a little bit of prednisone, not much. And then the final culture came back E. coli, which isn't a huge surprise when you learn that he eats his own poop routinely. But so we went up there, and UW medicine comes up. Oh, well, this is E. coli. We're going to treat with prednisone, ciprofloxacin, watch out for tendinitis in a gorilla. And I was sitting around with all the vets and the gorilla keepers, and I said, and if this was a human, we'd be doing saline irrigations. And I said, do you think you guys could do saline irrigations on it? And the room got really quiet. And they look around, and they looked at me, and the head guy says, you do it first. So I adjusted our plan. He got really sick, though, within about a week of starting that regimen. And so he went by zoo ambulance, police escort, about a 5-mile drive from the zoo up to this, the Center for Diagnostic Imaging. One of the radiologists here is a board member of the zoo and donates his time and services to the zoo. He's got great pictures of a porcupine in a CT scanner, which is amazing. So we took Vip here. And this is him on the CT scanner. He was intubated at the zoo and transported. He weighs 430 pounds. The upper limit on the CT scan was 400 pounds. It wasn't working, and just because he was too heavy. The trick was to get him off the backboard, which he's on here, and that helped distribute the weight a little bit better. So we finally got the CT scan, but before that I did an endoscopic collected culture. And the gentleman in the green scrubs behind me, that's Dr. Collins. He's the head vet. And at first I thought he was just caring about the animal, but then he was more concerned about what I was doing to his priceless gorilla when I stuck the endoscope in. And this is going to be evident soon, but within about 30 seconds of the endoscope, rigid endoscope in the nose, it started bleeding pretty good. His tissue was very friable, and fortunately I brought some Surgicel and just put some in there, and that stopped things. But we got the scan, and this is pretty interesting. They have very, very similar anatomy. It's a little bit longer and a little bit more narrow, but you can see he's got frontal sinuses, maxillary sinuses here. And what's fun is if you compare him to humans. And granted, most of us have frontal sinuses. Looking a little bit further back, he has ethmoid sinuses, similar to us, although they're smaller. He even has an anode cell, which is pretty interesting. And then sphenoid sinus. And then here's the really fun shot, is the sagittal crest. And the sagittal crest are where these huge temporalis, jaw crunching muscles attach. We don't have that, obviously. So most of the gorilla head is muscle. And when you look at the intracranial cavity, the little brain cavity, this is what's so amazing. And I know if their brain was the size of our brain, we would be in the zoo and not them. So we're fortunate. He was sick, though, as I said. He started to get facial edema. You can see he has some maxillary sinus erosion. He also has some skull base erosion. And this is a gorilla skull that we also did a CT scan just so I could get a little bit better understanding of the anatomy. This is Kiki, who died about 10 years ago. And you can see if you compare both of these and looking closely at the nose, we have septums, and they're deviated as well, and inferior turbinates. And if you look at that, you really couldn't tell one from the other based off of their nasal anatomy. So as I mentioned, he got critically sick. And what was so nice in retrospect is he got sick about 4 days before Amy was putting on her sinus course at Virginia Mason. So all of this equipment happened to be in Seattle. It was just at Virginia Mason. Some very rapid phone calls and high executives helped, because this is the Woodland Park Zoo operating room. It's great if you need to drain an abscess or something, but there's nothing about doing endoscopic sinus surgery in the veterinary community in gorillas. So with a lot of corporate sponsorship from Medtronic Stores, Intersect, Baxter, Cook, Valley Labs, Spyway, and UW Medicine, I did have to get Dean's approval to have the zoo as a site of practice. So my malpractice was covered. They did that. I wasn't going to touch him without 3D navigation, and it did work, which was fantastic. So we transformed the zoo operating room into just essentially the same OR suite. Same equipment that you guys used here yesterday, we used at the zoo. This is late last summer. This is Kelly Helmick, who is intubating Vip with a garden hose. And here's the interesting thing, in thinking about how this is why I caused a nosebleed. You can see on this video, it's a little dark, but see how his nose stretches when I pull it up, and then you relax it? It accordions out and in, so it's not a straight path like ours is. It's a very floppy, circuitous pathway. So if you put a straight, rigid instrument in, you're going to hit the side wall. And that's what I did to cause the nosebleed. It was helpful knowing that ahead of time. So we set up the navigation, and this was just like any other surgery. My normal scrub tech, Jamie, came to assist. My circulating nurse, Karina, was there as well. And it all looks the same until you look down and you see fur and gorilla hands and feet, and it's just bizarre. And here's Dr. Collins. He's like, what is this guy doing to my gorilla? But he was there the whole time. Here's some intraoperative shots. We set up the navigation, and looking at his nostril, this is on his left side, it's very edematous, and this is the thick debris that was within his maxillary sinus. And here I'm thinking, I just wished it was a straight shot, easy sinus case, but one of the worst ones I've ever had to do. This is using the Spyway, something that Dr. Mo invented, and it protects the nostrils. I happen to have one, and it really helped out keep that nose stented. Massive polyposis throughout. I thought this was going to be a sinister lesion or at least an inverting papilloma. It wasn't. It was just an inflammatory polyp. And this is his nasopharynx, which was completely blocked off from his nostrils. Here's the right side. That's his middle turbinate. You can see polyps laterally. Here's his uncinate process that I fractured in a classic sweep bar technique with the second life. And then I went on to just do the rest, the ethmoids, the sphenoids, and then I ballooned the frontals because he started to get light. You see him breathing and his nostrils flaring there. I did stick a propel in on each side because they did not want him to be on prednisone. They wouldn't do budesonide irrigations, and this was the only way I was going to get some steroids to that area and also keep that there. So kind of said our goodbyes there. This is Fred, who's one of my residents and assisted me as well. But just a very surreal day. Here are the gorilla keepers who care for these gorillas as much as they would a family member, and they were there the entire time. How do you extubate a gorilla? Wow. That's the challenge. And so this is one of the rooms in the gorilla house, and you can see there's a little window it's actually a door, about a 2 by 2 foot door, where the gorilla keeper will put him in this lateral decubitus position, wait until he's pretty much spontaneously breathing, and then pull the tube. And that's it. There's no jaw thrust. If he goes down, they're going to have to ketamine dart him again and try to hopefully get the whole process over. So this is the most concerning and scariest part of the whole day, was the extubation. Seeing him post-operative day 1, you see signs like this: dangerous area, stay away. This is the backside of the gorilla house. And this is what he looked like on post-op day 1. His facial swelling had dramatically decreased. So his eyes were completely shut the day before surgery. This is not me feeding him grapes. That's one of the gorilla keepers. I feed him long things like carrots and melon. And he was walking around doing great. We're all high-fiving each other, thinking, this is fantastic, this is fun. And then post-operative day 3, the call came, something's wrong, Vip's not doing well. And sure enough, his facial edema came back horribly wrong. He developed this huge cutaneous fistula below his mandible. Turns out he was on the wrong antibiotic based off of the sensitivities at the time of surgery, and the vets had to dart him twice a day to give him his antibiotics because he was really sick, got back to not eating or drinking anything. And this is a concerning finding, which I've never seen in a human, but that's his right orbit, and wait for it. There you go. So, super sick guy, but a few days later, he just got better. And I was so worried at this point, I was telling the head vet, Darren Collins, like, we got to go back to surgery, wash him out, and blah, blah, blah. And he's like, just wait. Gorillas, they have amazing immune systems. He's been eating his poop his whole life. He's going to be fine. And sure enough, he did get better, a lot better. And there are times where we rush patients back to surgery because we're so concerned about various things. But man, the immune system's amazing. This is his fistula about a week later, and then 2 weeks later, and just spontaneously closed. Did not have to do anything. Day 5, this is kind of backtracking a little bit. Day 5, I went in to see him, and at this point, I've met him probably 10 times before and after surgery. And I was on vacation this week, came straight from horseback riding with my family, and I sat down to see Vip, and he always runs up to the cage and slams himself against the cage to say hi. That's how he does it, and exert his dominance. And I sat down on the little tiny stool, and all of a sudden he throws straw at me. I'm like, hey, Vip, you're feeling better. That's great. And then half a second later, I'm covered with this hot, sticky E. coli Vip poop. But I just laughed. I was so happy he was feeling good enough to do that I walked out and I wiped off and I went back to my car. My wife and kids were waiting for me. And I said, does anything smell funny? And my wife goes, no, but you got something on your ear. And I had missed a spot. So that was my second baptism. But 2 weeks later, he just continued to make great progress. And again, this is the vets. They were darting him with antibiotics. They were hand feeding him, giving him liquids, really great supportive care. And I got to visit him as well and feed him things like this. The little nuggets are called monkey chow, which I didn't know. It's pretty fun. And this was him about a month later, looking ornery as ever. He finally went back to the outdoor exhibit and started socializing with his women gorillas, which is what he likes to do. 6 weeks later, so he had a fractured canine. It was planned for him to go back and get that canine worked on. I had an x-ray, and I asked him to x-ray the sinuses as well. He had a little bit of stuff in there, so Storrs and Medtronic brought some stuff in, and I was able to clean it out. I brought Dr. Futran up. Dan Seeley's there as well in the very back. You guys know Dan. He came by to say hi, and this is what he looked like 6 weeks after his initial surgery. This is going in his left nostril, which was his bad side, and there's still some debris. Interestingly, no fungus in the first specimens. A little bit of fungus on this one, but we have been blasting him with antibiotics. This is the right side. That's his maxillary sinus. There's some gorilla snot. And again, the right side improved really well. Little tiny polyp back there. Put another Propel in on each side just to give him more steroids. And, polyps come back. This surgery was end of August of last year, and we'll see how he does. There's, just like humans, there's probably a chance that we might have to go back. But this is how he looked 2 months later. And then the best Christmas present I got, this was, let me preface this. This is inside his sleeping quarters. And there are a lot of hanging fire hoses. I got an email from Dr. Collins. He says, Vip was having gorilla-friendly relations with one of the females while climbing on the fire hoses last week. The aerial copulations on the suspended fire hose is a great indicator of how well he is feeling these days. It doesn't get any better for a male gorilla. So this was a fun adventure. Couldn't have done it without our corporate friends. And one of the key things that I like to tell people when I give this talk, you too can volunteer for your local zoo. They're dying to have specialists help them out from time to time. So go and meet the vets, give them your card, and from time to time, you might get a phone call. But thank you for the time to give that talk. I appreciate it. The last thing I have, every now and then at these courses, somebody has a burning desire to ask a question to one of the panelists or one of the faculty that have been here. In the last 5 minutes, does anybody have a question they want to ask to one of the faculty members? No burning question, we answered it all. Because I have, yes, I'm going to give you the mic though. Phil Donahue here.
Thank you. I have a question about operating on recurrent sinusitis, acute sinusitis, and with clean CT. I don't like to do that, but I have colleagues who do that, and I just want to hear the panel's opinion.
I was going to ask the exact same question. So excellent job. Do you mind answering?
Well, I alluded to it in my talk. I almost never operate on recurring acute rhinosinusitis anymore. The only reason or clear reason for me is when the bouts are not improving and they're painful bouts that maybe alleviate the pain during the bouts. It's not going to get rid of the problem. But really understanding the etiology and counseling the patient properly, looking for avoidance, waiting for the school-age children exposure to subside over time is better than the actual surgery experience. I can't think of any patient in the last 3 or 4 years that I operated on for this diagnosis. Again, I have a tertiary referral practice, so I may not be the only person who could be best suited to comment on that.
Any thoughts from the other panelists? You know, there was a paper that came out recently about that recurrent acute sinusitis. The challenge is, how do you know they're really having recurrent acute sinusitis? And that's what concerns me. You know, I'll admit there are patients that I've done minimal FES on. I think the balloons might have a role in this, but you really, for me, you really got to make sure that they have an infection. And my mental checklist, I want to see one CT scan with abnormalities, true abnormalities. So I'll write an order for a CT scan, and they'll call my nurse when they feel that, hey, this is it. I need antibiotics now, or I'm not going to make it. Then I'll come in, get the CT scan when they're at their worst of worst. If it's totally normal, then we're done, and they're off to the neurology headache clinic. All right. Well, we're at lunchtime, and far be it from me to ever hold up food. You guys have been a fantastic group to work with. We're going to send you out a survey. Please, as Dr. Backus mentioned, please let us know if there's anything we can do to make things better. We will. And I know you're all sad that Rhinology is over and we have to switch gears to Otology, but thank you very much and hope to see you in subsequent years.